Hello guys, good morning. I believe you're all fine. So this morning we are going to discuss on the emergency stations, and then we'll start with shoulder dystocia. So the emergency stations, there are 4. We have shoulder dystocia, postpartum hemorrhage, unexpected breech birth, and then postnatal sepsis. Okay, so these are the 4 emergency stations, and they mostly put them together as paired. So most of the questions that students I come across mostly meet is shoulder dystocia, and then they'll move on to postpartum hemorrhage. So we'll start with shoulder dystocia. Okay, all right then. It's all right. So as an emergency station, the marking criteria, we're going to digress with the marking criteria, break it down, then I'll move on to performance and the examination condition. So the marking criteria doesn't start with washing of hands, scene safety, privacy and dignity. No, this one, it starts straight away from you recognizing the emergency. So you may be given, you'll be given a scenario. Okay, one example could be that you just took over from the day shift or from the night shift, and Amy Hall or Lisa Molloy has been in labor, in the second stage of labor, for over 2 hours now, and then the attending midwife has to be on break. Okay, how are we going to care for this woman? Okay, so as soon as you are given that and your time starts, the first marking criteria says that recognizes the emergency and call for help, recognizing the need to use the emergency buzzer, declares the emergency clearly, stating shoulder dystocia, and recognizes the need to request assistance from the appropriate members of the multidisciplinary team. Verbalization is accepted. So recognize as an emergency depending on the scenario you have been given. Okay, so second stage, the woman has had a prolonged second stage of labor. Okay, and then as labor you try to deliver. So if you try to deliver and there is a compartment and it's coming forth, okay, then you can say that, oh, I recognize this is shoulder dystocia, which is an obstetric emergency. I am calling for help. Okay, then you quickly move on to press on the call buzzer. All right, okay, and then you ask the first respondent to dial 2222, states dial 2222. This is an obstetric emergency, which is shoulder dystocia. I request for the presence of, we use the acronym SOAPs. So you are requesting for help for senior members. And who are these senior members? So you use the acronym SOAPS. So the S is the senior midwife, the O is obstetrician, the A is anesthetist, the P is pediatrician, and then the S is a scribe, somebody who will scribe for you. Okay, so in the UK here, the practice is that while there is an emergency ongoing, somebody should be writing down the treatment line that is being given. Okay, so maybe at this time, emergency buzzer was called, soaps arrived, first observations, maybe blood pressure was this, pulse rate was this, infusion started at this time, what is the name of the infusion, the flow, the amount, second dose of oxytocin given at this time. So that will be the work of the scribe, that is needed so that you can use it to fill the pro forma, you can use it to fill the incident report form or the data and all other documentations. So that is important, so please do not forget about that one. Okay, so that is the first one. I'll repeat again. You recognize the emergency, call for help. Okay, you call for help by what? Using the emergency buzzer. You then state the emergency, declare it that this is shoulder dystocia, and you need the presence of the senior midwife, the obstetrician, the anesthetist, the pediatrician, and the scribe. Okay, number 2, that's the number 2 on the criteria. ask the woman to stop pushing, and then reclines the back of the bed. Okay, so if the woman is sitting up while pushing, or yes, the back of the bed was lifted up, flatten it up down. Then you take any extra pillows there. All right, yes, you want the woman to be flat. Okay, and then yes, so that's here. The third one is carry out McRoberts maneuver. Okay, so this one, most of the time when we ask the woman to stop pushing, recline the back of the bed or the couch, remove any pillow from the mother's head, we also ask them to come closer to the edge of the bed, even though it's not here, it's not on the marking scheme. So you can still ask the woman to come closer to the edge of the bed, all right? And then you carry out McRoberts maneuver. And McRoberts maneuver, so this is the first maneuver. So there's a compartment against the descent of the presenting part, okay? And this compartment is by the shoulders, okay? So we know what is happening in shoulder dystocia. This is the pelvic cavity, all right? And then the shoulders have been lodged against the pelvic cavity. Okay, so let's say this is the shoulders of the fetus. Okay, and then you want either the shoulder to fall down, okay, this way, so that the rest of the body will follow and will be delivered onto the maternal abdomen, okay, or the pelvic outlet. So let's say the baby has now, engagement has taken place, descent is also there, okay, but then the obstruction or the lodgement or the compaction is situated at the pelvic outlet. You know, we have the pelvic inlet, the cavity, and the outlet. So if it's at the outlet, then we want the outlet to be able to open up. We know that the sacral, the causes bone, the tailbone, which is the causes bone, can tilt back and help to increase the pelvic outlet. We also know that some positions can also help open up the pelvic outlets and then the vagina. Okay, so these are the positions and the maneuvers we are going to apply to be able to deliver the fetus. Okay, so the first one is McRoberts maneuver, and this is done by hyperextension or hyperflexion of the maternal thighs, okay, onto her abdomen. So the woman is lying down, okay, then you hyperextend the abdomen, hyperextend the feet or the legs or the thighs towards her abdomen, just to create more space at the pelvic outlet to help reduce the compartment and deliver the fetus. Okay, so that is number 4. That is number 3. Carries out McRoberts maneuver, which is hyperflexes the mother's legs towards her abdomen. Once this position has been achieved, applies routine axial traction to try to deliver the fetal head, supporting the woman to roll over into all 4 positions instead will likely have the same effect and is a decision of the midwife. So we have, for the first maneuver, we have 2. Either you perform the McRoberts maneuver, okay, or you perform the all fours. So the all fours, you have the woman's feet, both the hands and the feet, okay, going on the floor, on the bed this way, right? Then you have the back, the pelvic outlet, the vagina, and yes, all of it opened up widely, okay. Now this will depend on the woman's condition. If the woman is stable to assume that position, then you help her into the all fours position, okay. As there is movement and then changes and all of that, we are expecting that those movements or those shifts should also affect the compartment for the baby to move down, okay, into the outlet, all right. And then as she extends her buttocks out and then tries to open out, the pelvic outlet is also what will also open up. Okay, yes, for the fetus to come out. All right, so that is that for number 3. I repeat again: carry out McRoberts maneuver by hyperextension or hyperflexion. We are going to use one. We could use a hyperflexion if you remember. Carry out McRoberts maneuver by hyperextension of the maternal thighs onto her abdomen. This is to create more space at the pelvic outlet to deliver the fetus. Or I may assist the woman into all 4 position as her condition will allow. Okay. Then apply axial traction to deliver the fetal head. This is axial traction. So you want to, instead of, back home, some of us deliver like this. So this to the neck or the nape of the fetus, and then trying to deliver. So here, it's not like that. You use the axial traction, right? Okay. So that one goes this way. This one. This is at the nape, the neck. I should put it this way. So you are trying to deliver it in a straight line. You get it? In a straight line. That is the axial traction. Okay. All right then. So you have applied McRoberts. You have tried the axial traction. Can this baby's head be delivered? No, it's still compacted. Okay, so what is the next step to do? Number 4, apply suprapubic pressure from the side of the fetal back. This should be applied just above the maternal symphysis pubis in a downward and lateral direction. This should be conducted for no more than 30 seconds. So in short, apply suprapubic pressure just above or 2 centimeters above the symphysis pubis of the mother. Okay. Downward and laterally of the fetal back. Okay. All right then. Okay. So this way, just like you conducting cardiac, what am I saying? Okay. So you put your hand in this position, okay, the dominant hand over the non-dominant one, okay, and then as if you're going to give resuscitation, okay. So here, this is the symphysis pubis. Just here, you apply. So the fetal back, either this way or this way, you would know. Maybe you'll be given the position, all right. But that one, don't even be bothered about the position. We just want you to demonstrate it. So at the symphysis pubis, downward, laterally, downward, laterally, downward, laterally. I don't know if you're downward and laterally, because you are trying to reposition the fetus into the best, into the best position that will allow the fetus to come out. Okay. So if my shoulders are like this, and then you apply downward laterally, downward laterally. How? Okay, this way. So downward laterally, downward laterally, downward laterally. It means you are helping me to reposition me in a way that will help me to come out. Okay, so that is the suprapubic pressure. So after the McRoberts, okay, apply axial traction to try to deliver. If you are not able, if I'm unable to deliver the fetal head, then I'll apply suprapubic pressure, okay, downward and laterally, just above the symphysis pubis, and this should not exceed 30 seconds. Please remember, do not continue with downward laterally, downward laterally. Okay, some people say rocking motion, so this is rocking motion, is it not? Rocking, rocking something, so it's the same thing. Downward laterally, downward laterally, downward laterally. It's the same as a rocking motion. Okay, so that should not exceed 30 seconds. So when you do it for 30 seconds, you stop. Okay, all right. You can repeat this when, after all the maneuvers, the fetus is still not born. You could repeat this process again. But if you are told that your fetus is still not born, you say, okay, you still move your patient to the all-fours position, and then I'll try routine axial traction to try to deliver. If this does not work, then then the final resolve will be So when we get there, you give the final results. Fine. When we get there, mention it. Okay. So after the suprapubic pressure, then you evaluate for episiotomy. Okay. All right. So now I'm going to evaluate for episiotomy. Or for me, I say that after the suprapubic pressure, I'm going to conduct the internal maneuvers. But just before that, I'll assess if there's a need for episiotomy. Okay. So you assess if there's, so you go in just like doing VE. Go into the vagina walls. Go into the vagina. Try to see if there's space or it's just too tight. If it's too tight and does not allow your fingers to go through, then there's a need for episiotomy. So I have entered and I'm assessing for episiotomy. The vagina is roomy. There is more space, so there's no need for episiotomy. I'll move on. Then I'll move on into the internal rotation, okay, by putting my hand in scrunched fingers. So by scrunching my hand, scrunch, 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 or putting my fingers together. By scrunching my fingers, okay, so let me read. You attempt to deliver the posterior arm. Vaginal access should be gained posteriorly with fingers scrunched together while straight. Okay. Okay, so you ask the patient, Lisa, I would like to enter your vagina to deliver the fetus's posterior hand. Should I go ahead? Okay, so in a scrunched finger, I'll go in a straight line, or in a scrunched finger, I'll enter the vagina to reach the posterior arm. The posterior arm, so I am the fetus now. I am the fetus now. This is my presentation. This shoulder is being compacted. Okay, so this aspect that is closest to the maternal posterior, the back of the mother, is my posterior arm. This aspect that is closer to the abdomen or the anterior of my mother is my anterior arm. So posterior arm, anterior arm of the fetus. You understand that one? Okay. So it says that attempt to deliver the posterior arm of the fetus. So we are going to attempt to deliver this arm. The arm could be this way, 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 the arm could be anything. So I enter with a scrunched finger. I'm trying to get the wrist. Okay, I can't find the wrist. All right, but if I enter with a scratched finger and then I could easily get the wrist. Oh, this is the fetal wrist. Then it says that deliver in what? In a straight line. Okay, and then the fingers will come across into the maternal perineum. So I'm going to read again. Attempt to deliver the posterior arm. Vaginal access should be gained posteriorly with fingers scrunched together while straight. Once the posterior arm is located and the wrist reached, the arm can be delivered in a straight line. Once the arm is delivered, routine easier traction should be applied to deliver the baby. I hope you understand. Okay. I'm going to repeat. I enter into the maternal vagina with scrunched fingers in an attempt or trying to reach the posterior arm. Okay. Or trying to reach the wrist of the posterior arm, because you need the wrist to be able to deliver it down. So I enter into the maternal vagina, trying to reach the wrist of the posterior arm, okay, and deliver it in a straight line. If this is possible, I'll continue to apply, or if this is delivered, I'll apply easier traction, routine easier traction, to try to deliver the fetal head. If I'm unable to reach the wrist of the posterior arm, then I will attempt another internal rotational maneuver. Okay, so this is most successful when pressure is applied to either the anterior aspect or the posterior aspect of the posterior shoulder. Okay, so again, posterior shoulder, anterior shoulder. We are concentrating on the posterior shoulder because that is where, as soon as you put your hand into the vagina, that is where you reach. So now we have tried to get the wrist down. We could not reach it. So what is the next thing? The next is we are going to rotate either the posterior, this is posterior of the posterior arm, posterior of the posterior arm, anterior of the posterior arm, or back of the posterior arm, front of the posterior arm. So we are going to attempt to rotate the back of the posterior arm. Okay. So you are going to rotate the back of the posterior arm. So you are going either way, either you rotate it this way will be in a clockwise direction or anti-clockwise direction. All right, for you. Or so you try with first one. So you start with the posterior. We are going to rotate the posterior aspects of the posterior arm. Okay. Where is this? So you're going to apply pressure. We're going to rotate the posterior aspects of the posterior arm to help reduce or to help turn the fetus in a favorable position so that you can deliver the head. Okay. So when you touch it this way, when you feel it, you look at how you feel the posterior arm. If you think there's more space, okay, towards you, your left or your right, you push it that way. Then you try to deliver the fetal head with a routine traction. But if this does not work after the routine traction, if this does not work, then you enter again, and then you try to rotate the anterior aspects of the posterior arm anti-clockwise. Okay. So for you to be anti-clockwise, for me the clock going this way, will be, for me it's clockwise, but for you to be anti-clockwise. So fine, let me use my own as clockwise. Posterior arm, anti-clockwise. Okay, and then I'll apply routine traction to try to deliver the head. If this does not work, I'll enter the vagina again, okay, and then find the anterior aspects of the posterior arm and then rotate it clockwise, okay. Then I'll try to deliver again with the routine axial traction onto the maternal abdomen. Then if this does not work, so by now maybe the examiner will tell you, okay, the baby is delivered now, then you deliver onto the maternal abdomen. But you may get somebody who will say, still, the baby is not delivered, so you continue. So you continue to say, if this does not work, she will say, okay, deliver the baby now, then you deliver. But when you say, if this does not work, she may still be holding on to the baby. It means the baby is not, she is not delivered, so you continue. If this does not work, support the woman to roll over into all four positions or verbalize the possible benefits of this change in position. So if this does not work, I will help the woman to assume the all four positions. Please, you understand? So you have mentioned all fours twice. It could be used instead of the McRoberts, okay, from the beginning, or it could be used after the internal rotations, okay, or somebody would want to use the all fours after McRoberts and still repeat it after the internal rotation. All right. So if this does not work, I'll help the woman to go into all fours position, okay. This will help increase the pelvic outlet, okay, and then help help to deliver the baby in axial traction, or apply routine axial traction to deliver the baby onto the maternal abdomen. Okay, so then you say that if this does not work, then I would recommend final results or what is it called, additional maneuvers. If this last all fours position does not work, then we will attempt the final maneuvers, which is cephalic replacement and symphysiotomy. So you say this one verbalization is accepted because you're not the one who will do that one. but you discuss with the team that, okay, or we have applied it, we have repeated the positions. So remember, at the last all fours, if the woman says, if the examiner says still the baby is not delivered, you say, I will try the McRoberts position again, and then try all the internal rotations again. But then I would have to look at the progress and the condition of the woman, if it permits. If not, then we will consider the last resort, which is under anesthesia for cephalic replacement and then symphysiotomy. Okay. So this is that. Then you come and verbalize the need for the midwife to ensure that the woman understands what has happened and has a chance to bond with baby. Shoulder dystocia marking criteria verbalizes the importance of maternal observations to establish condition and the importance of completing all relevant documentation. Okay, so the last of this, okay, the last but one, I'll put it that way, is that you use your 3Ds. You debrief the woman, partner, and staff about the incident that has happened. You document the whole process, okay, and then fill a DATIS form. DATIX. DATIS. DATIS is also called incident report form. So you fill incident report form. Then you complete shoulder dystocia pro forma. Pro forma, PROFORMA. So pro forma for shoulder dystocia will also be completed. It's part of the documentations that you do. Okay. And then so debrief documentation, and then you would continue with observations of the woman, and then ensure that bonding between the woman and then the newborn is established. So bonding could be through breastfeeding or be established. Then you continue to observe the woman, observe the vital signs of the woman, okay, for the progress of her condition. So both the woman and the mother. And then for the baby, when you're able to deliver, okay, you look at, so after delivering the baby, you would then look out for any injuries or trauma, okay, to the newborn. It could be brachial plexus injury, or trauma to the head, okay, or subconjunctival trauma, or you could say yes, subconjunctival hemorrhage, cephal hematoma, whatever, caput sidonium, any trauma on the newborn. So you watch out for injuries and trauma, cephal plexus injury, okay, to the newborn. Then you also look out for perineal tears, that needs suturing for the woman, and then blood loss, okay. Then you continue with observations of the mother. Okay, so these are the things you say after all the documentations. Then you wash your hands or maintain hand hygiene according to World Health Organization 7 steps guidelines. All right, so you would say that one from the beginning. The hand washing is more important, but when you end, it is the last one on the marking criteria. Verbalization is accepted. All right then, so this is the explanation for shoulder dystocia. All right, okay, so I hope if there are questions, anything, you could send it over. So I'm going to repeat. Okay, I've taken over. Okay, hello, I'm trying to help with easier traction to deliver the baby. Okay, the baby is compacted. This is an obstetric emergency, which is shoulder dystocia. I'm calling for help. I'll put the emergency as the first responder comes. Please dial 2222. I have shoulder dystocia and I need the presence of senior midwife, obstetrician, anesthetic, pediatrician, and a scribe. Okay, stop pushing, Amy. Let me help you. Recline the bed to lie you flat. Come closer to the edge of the bed and I'll take all the pillows off. Okay. Now this is shoulder dystocia. We are going to try maneuvers to help decrease the compartment of the fetal head, okay, compartment of the against the fetal shoulders, okay, and help deliver the newborn, okay, or help increase the pelvic outlet, okay, so the newborn could be delivered. All right, so the first maneuver is for the McRoberts maneuver. I'm going to hyperextend your feet onto your abdomen to create more space at the pelvic outlets. I'm going to apply routine nasal traction to try to deliver the fetal head. If this does not work, then I'm going to apply suprapubic pressure, okay, downward and laterally, just above the symphysis pubis, and this should not exceed 30 seconds, okay. All right, then if this does not work, then I would consider the internal rotation. But before that, I have to assess for episiotomy, okay. I am going to go in. Can I go in, please, into your vagina, miss, to assess if there's a need for episiotomy? The vagina is roomy, it's not too tight, so I'm not going to give episiotomy, okay. And now I'm going to try to deliver the posterior arm, okay, I'm going to try to deliver the posterior arm of the posterior shoulder, all right, by going in scrunch fingers, trying to reach the wrist of the posterior arm. If I'm able to reach it, I'll deliver it in a straight line, okay, into the maternal perineum. If I'm not able to reach it, then I'll go in again with my scratched hands to try the internal rotations, okay. So as I go in, I'll locate the posterior aspects of the posterior shoulder and then rotate it, okay, anti-clockwise, okay. This will help move the baby into a favorable position for this. It will help move the fetus into a favorable position to be able to deliver. I'm going to apply axial traction to try and deliver, okay. If this does not work, then I'll try the other way. I'm going to apply pressure, okay, or rotation against the anterior aspects of the posterior shoulder clockwisely, okay, and then try to deliver with axial traction, routine axial traction of the fetal head, okay. All right, then if the fetus is not delivered, then I'll reconsider helping the mother into all fours position, okay, as the mother's condition will permit. All right, okay, so into all four positions, so help increase the pelvic outlet, okay, and then the movements may also help reduce the compartment or bring a shift, okay, in the fetal position and for a possible delivery through routine axial traction, okay. If this does not work, then per the woman's condition, if one is able, then I would want to repeat the steps or look at the final results under anesthesia, which is cephalic replacement and then symphysiotomy. All right, okay. So when baby is delivered, I'll now look at the baby's conditions, look out for trauma injuries, brachial plexus injuries, okay. And then if any of these is identified, hand over the newborn to the pediatrician, okay. If baby is fine, then I'll put baby on mother for skin to skin and then to continue with bonding. Then I have to look out for the mother's perineum for any tears that need suturing, blood loss, okay, and then continue with observations of the mother, okay. Now I'm going to debrief the mother in parts now on what has happened. Start with my documentation of all that has happened. Fill the pro forma for shoulder dystocia. Complete a data or incident report for the shoulder dystocia, and then yes, continue with bonding between the mother and the woman, and the observations will also continue, okay. Then keep mother warm and then clean. I'm now going to maintain hand hygiene according to World Health Organization 7 steps guidelines. Palm to palm, back of the palm, place on the fingers, back of the fingernails, the wrist. Allow it to dry for 30 seconds. Thank you. Okay.